Hi, ladies. Okay, so we're getting ready to do our chapter 27 lecture and PowerPoint slides. It's on inpatient versus outpatient coding. You're going to be using your ICD-10 this time, a little different. But I hope that you enjoy the ICD-10. I know that it's my favorite. I enjoy it. I think it's fun. So here we go. Let me get our stuff up and running so we can get this party started, as they say. So chapter 27, inpatient coding. Inpatient versus outpatient coding. Sorry guys, I have to turn my phone down. I forgot to do that. I apologize. All right, here we go. One of the most important considerations during the medical billing and coding process is to choose whether the patient is an inpatient or an outpatient. Based on the choice, the medical codes associated differ. At times, inexperienced medical coders may unintentionally misrepresent the patient's status, which could result in denied claims and even accusations of fraud. What's the difference between inpatient and outpatient coding? By the end of this article, you will know the difference between inpatient and outpatient services. Now, I don't know, maybe all of you know this, but I'm just going to make a point that inpatient and outpatient codes in the CPT are found in the E and M section, Evaluation and Management. Inpatient medical coding. Inpatient coding is related to the patient's extended stay service. Examples of inpatient facilities include acute and long-term care hospitals, skilled nursing facilities, hospices, and home health services. Here's why this matters. During the stay, the patient may have a variety of tests run. We'll have changes in diagnosis and treatments. A lengthy stay usually results in extensive and intricate patient records, which makes it important to have an experienced medical inpatient coder doing the job. So what is outpatient care? Who is an outpatient and what is the outpatient services? Okay, so we're going back to what is an inpatient. I don't know what why this didn't transition better, but anyway, we'll go back to inpatient. An inpatient is an individual who has been officially admitted to the hospital under a physician's order. The patient will remain classified as an inpatient until 1 day before discharge. Staying in the hospital overnight does not necessarily mean that the patient is considered an inpatient. Okay, so here we're going into outpatient. A patient that comes into the ER or practice and is being treated or undergoing tests but has not been admitted is considered an outpatient, even if the patient spends the night. Outpatient medical coding. Outpatient coding focuses on the direct treatment offered in a single visit, which is usually a few hours. A basic rule of thumb is that the outpatient care has a duration of 24 hours or less. Now, that's a basic rule of thumb, but it's not the only indication. With the increased development in the medical field, many services that used to be considered inpatient treatments are being assigned to outpatient services. A selection of inpatient principal diagnoses. Condition established after study, which are tests, chiefly responsible for patient admission and applies to all non-outpatient settings. Acute care, short-term, long-term, and psychiatric hospitals, home health agencies, rehab facilities, nursing homes, etc. So we're going to talk about the selection of inpatient principal procedure. Codes from the ICD-10 PCS. Principal procedure is definitive treatment rather than diagnostic or exploratory, which means it's definitive what they're being treated for. They know exactly what's going on. Necessary to take care of a complication if 2 or more procedures meet the criteria. Report One most closely related to principal diagnosis. So the procedure is significant if it is surgical in nature, carries a procedural risk, carries an anesthetic risk, requires specialized training. So we're going to watch a little video on selection of principal diagnosis.
Hi everyone, Dr. Campbell here, and today we're going to take a look at Section 2 of our ICD-10 CM guidelines, which focuses on the selection of the principal diagnoses. One of the things that you'll want to note is that the circumstances of the inpatient admission is always going to govern the selection of the principal diagnoses. The Uniform Hospital Discharge Dataset actually defines the principal diagnoses as the condition that's established after study to be chiefly responsible for occasioning the admission of the patient to the hospital for care. I personally remember the words after study. In determining the principal diagnoses, your coding conventions, which are actually in Section 1 of your guidelines, and the tabular list and the alphabetical index actually take precedence over these guidelines. There are several circumstances that you'll want to consider in selecting your principal diagnoses. So let's take a look at them. First up is related to situations where you have signs and symptoms. Signs and symptoms are not to be used as a principal diagnosis when a related definitive diagnosis has been established. So think about someone that has chest pain and the doctor definitively says that the patient has a heart attack. So we would not code the chest pain, we would just code the myocardial infarction. Another guideline is a situation when there are two or more interrelated conditions that are actually each meeting the definition of principal diagnoses. And when we say interrelated, what we mean is diseases in the same ICD-10 CM chapter or manifestations that are characteristically associated with a certain disease. In those particular situations, either condition may be sequenced first unless the circumstances of the admission or the therapy that's provided, the tabular list, or the alphabetical index tell us otherwise. Next up, situations where two or more diagnoses equally meet the definition for principal. So notice how that's different than the previous guideline. The previous guideline talked about two or more conditions that are interrelated. Here, we're talking about two or more diagnoses that equally meet the definition. Now, this isn't in an unusual instance that two or more diagnoses equally meet the definition of principal diagnoses. The guidelines state that either of these diagnoses may be sequenced first. And you also want to consider whether or not the alphabetical index or the tabular list or other guidelines in our code set is not giving us any other options. All right, next up we have two or more comparative or contrasting diagnoses. And here you're going to see where the provider is saying something like either or this condition. They are coded as if they are confirmed, and we're going to sequence our diagnosis. And when we say sequence, which one goes first, according to the circumstances of the admission. Next up, situations where the original treatment plan is not carried out. So let's say a patient comes in today because they're going to have a cholecystectomy because they have cholelithiasis or cholecystitis, and the procedure or the treatment wasn't done. Coding guidelines tells us that even though the treatment was not carried out due to some type of unforeseen circumstances, the reason that they were there for the surgery is sequenced first. Of note, there is a status code, which is a Z code, that can indicate procedure not done due to whatever that particular circumstance was. All right, next up, complications of surgery and other medical care. So if the admission is for treatment of a complication from surgery or other medical care, the complication code is going to be sequenced as the principal. Of note, if the classification is, the complication is going to be classified to II.D through II.88 series of codes, and the code book does not give us the necessary specificity in describing the complication, an additional code for the complication can actually be assigned. Next up, we have uncertain diagnoses. Here, we're talking about when the provider at the time of discharge says probable, suspected, likely, questionable, probable, possible, still to be ruled out, or other terms that indicate uncertainty. You're going to code the condition as if it existed or was established. Now, the basis for these guidelines are the fact that there was diagnostic workup that took place, arrangements for further workup or observation, and initial therapeutic approach that would correspond most closely with an established diagnosis. Of note, this guideline only applies to inpatient admissions to short-term, acute, long-term care, and psychiatric hospitals. All right, next up, we're going to look at observation from, or admission, I should say, from an observation unit. So we have two guidelines to consider here. So first, when a patient is admitted to observation for a medical condition, which either worsens or does not improve, and then they're subsequently converted to inpatient status in the same hospital for the same condition, the principal diagnoses would be that medical condition that actually led to the hospital admission. Now, situations for observation following a post-op observation. So if a patient is admitted to OBS and to monitor them or for a condition or a complication that develops following outpatient surgery, and then they're subsequently admitted as an inpatient of the same hospitals, we're going to apply the definition of principal diagnoses, which again is what? The condition established after study to be chiefly responsible for occasioning the admission of the patient to the hospital. All right, next up, we're going to look at admission from outpatient surgery. So when the patient is outpatient, so they're receiving surgery in the outpatient surgery department, and then they're subsequently admitted for continuing inpatient care at the same hospital, there are essentially three different considerations that we need to make. So number one, we're talking about if there's a complication. So if the admission, inpatient admission, is for the complication is going to be sequenced as principal. If there is no complication or other condition that is documented as the reason for the surgery or reason for the admission, you're going to assign the outpatient surgery condition as the principal diagnosis, so the reason that they were having that outpatient surgery. And lastly, if the patient is admitted for a condition that's unrelated to the surgery, then you're going to assign the condition that's unrelated as principal. You always want to remember that codes paint the picture of the care that is provided today, and we want the insurance company to know why that patient was admitted. All right, lastly, we're going to look at admissions and encounters for rehab. So in those situations, when the sole purpose is for rehab, you're going to sequence first the code for the condition for which the service is being performed. Now, if the condition for rehab that's being provided is no longer present, then we're going to report the appropriate aftercare codes as the first listed or principal. Now, when you hear first listed, you can think outpatient. So it's going to be listed as principal unless rehab service is provided following an injury. Now, for rehab services following active treatment of an injury, you're going to assign the injury code with the appropriate 7th character to identify that this is a subsequent encounter. All right, guys, thank you so much for listening. And next up, we will take a look at Section 3 of our guidelines.
Okay, so that was, I just found that was very, very interesting. Guys, I want to make a point to let you know that I said to have your ICD-10 handy, and you're probably wondering, where are these guidelines? What is she talking about? But if you look in the very front of your ICD-10, well, it's not the very front, and I'm not going to give a page number because, well, it's page 1 for those of us who are doing 2019. I don't know the 2020, but it starts here. It says Introduction. And these guidelines are found through this section right here, and it is a lot of information. So that's why I'm trying to do it this way, so that you can get a very good overview of what's in these guidelines. But I would not, I would recommend that you do as much research on these guidelines as possible. So our next slide is diagnosis and services. Okay, what is the reason for the use of diagnosis codes? Well, they establish medical necessity for the documentation. Diagnosis and procedure must correlate. For example, if you're having a heart cath, your diagnosis isn't going to be an infection in your knee. It has to correlate. Medical necessity must be established through documentation. No correlation means no reimbursement. Okay, so section 2A, and I'm actually going to see if I can't actually point that out for you in your ICD-10. And Rachel, I'm so sorry, I've got to get the same book as you so that I can actually get you those page numbers. Okay, I'm looking for section 2. Okay, I believe section 2. I'm sorry, bear with me. I should have been more prepared. On page 44 for the 2019 book. Okay. Section 2A, symptom signed, and 3, defined condition. Inpatient coders do not code when definitive diagnosis has been established. These codes are not to be used for principal diagnosis when there is a related definitive diagnosis. So if you have a definitive diagnosis, you're not going to use your signs and symptoms. You're going to use your definitive code. Okay, section 2B, 2 or more interrelated conditions. Now, she did go over this when she was speaking, but I'm going to do it again. Okay, 2 or more interrelated conditions exist. Either could be a principal diagnosis, either sequenced first, and unless indicated otherwise by circumstances on the admission, therapy provided, and tabular list of alphabetic index. This is true for both inpatient admissions and outpatient visits. Neither code should be listed as principal, so the order does not matter. Either code. It says neither code, but it says, I think it's either code. If it's 2 equally related ICD-10 codes, either can be listed as the principal diagnosis. So for example, if you go in and it's cough and a fever, we could cough and a fever. If there's no ICD-10 code that covers cough and a fever, then you could use either or first. So we're going to talk about mitral valve stenosis. So this is an example of an interrelated condition. Mitral valve stenosis and coronary artery disease, 2 interrelated conditions. Either can be principal diagnosis. Either sequenced first. Either MVS, which is your mitral valve stenosis, or your CAD or CAD and mitral valve stenosis. Resource intensiveness affects choice. Mitral valve stenosis is presumed by the ICD-10-CM to be a rheumatic organ, or oh, I'm sorry. Let me say that again. I'm sorry. I'm going to try to get my tongue untied today. Mitral valve stenosis is presumed by the ICD-10-CM to be of rheumatic origin. When two or more diagnoses equally meet the criteria for principal diagnosis and coding guidelines, do not provide sequencing direction, any one of the diagnoses may be sequenced first. For example, diagnosis of viral gastroenteritis and dehydration, if both are treated, VG and D or D and VG. It doesn't matter. If only dehydration is aggressively treated with IV fluids and the VG is treated with oral meds, sequence the dehydration first. So you see that it's aggressively treated. So because of the aggressively treated, you're going to go ahead and list that first. This is going to be a rare occurrence. When two or more contrasting or comparative diagnoses are documented as either or, they are coded as if the diagnoses were confirmed, and the diagnoses are sequenced according to the circumstances of the admission. Okay, either or diagnosis, code as confirmed in the inpatient setting. If determination cannot be made, either can be sequenced first. For example, pneumonia or lung cancer can either be P or LC, LC or P, if both are aggressively treated. This is what the book is teaching you, but I'm going to tell you, as a coder, I would always put lung cancer first. That would just be me. I'm just telling you that that is what I would do. Okay, so section 2E, symptoms, followed by contrasting comparative diagnosis. When a symptom is followed by contrasting comparative diagnosis, the symptom code is sequenced first. The physician will state the diagnosis is symptoms due to X or Y. This is different from the previous section in which the physician stated the diagnosis is X or Y, instead of listing the symptoms. So the difference is the due to. So I'm just going to read what's here. Symptom code sequenced first. If a symptom code is integral to conditions listed, no code for symptom is reported. Then other diagnoses. Example, patient admitted for chest pain, either gastric reflux or peptic ulcer disease. Sequence first, chest pain, followed by gastric reflux or PUD. Rule, code first underlying condition causing the symptom. If it is necessary to code symptom to explain resource used, code also. Okay, so let's break that down a little bit. Let's look at our example is admitted for chest pain. So they think that the reason that he's having the chest pain is because of the gastric reflux or peptic ulcer. Okay, but they don't know that that's what he's got. They know for sure he's got chest pain. So let's go ahead with what we know for sure. We know for sure he has chest pain, so we're going to use chest pain. Then you can do the signs and symptoms, which it leads to, the signs are leading to gastric reflux or the peptic ulcer. I hope that makes sense. Section 2F, original treatment plan not carried out. Okay, the condition that occasioned admission to the hospital should be sequenced as the principal diagnosis, even though treatment may not have been carried out because of unforeseen circumstances. Conditions that after study was reason for admission as inpatient, treatment does not have to be carried out for the condition. Section 2F, example. A patient admitted for elective surgery develops pneumonia, the surgery is canceled. Code the reason for the surgery first, then code surgical or other procedure not carried out because of, I can never say this word right, for an unusual circumstances, contraindication. Y'all laugh with me. It's contraindication. Surgical or other procedure not carried out because of contraindication, Z5309. And then you would code also pneumonia. You're going to always place the reason the patient was admitted to the hospital first, even though treatment may not have been carried out. If a patient was admitted for elective tonsillectomy due to chronic tonsillitis, but when the patient came to the hospital was found to have a very high temperature, would the chronic tonsillitis be first or the fever? It would be the tonsillitis. Section 2G, complications of surgery and other medical care. If admission is for treatment of the complication from surgery or other medical care, sequence the complication code as principal diagnosis. If the complication is classified to T.80 through T.88 series and code lacks specificity to describe complication, an additional code for the specific complication should be assigned. Section 2H, uncertain diagnosis. The bases for these guidelines are the diagnostic workup, arrangements for further workup or observation, and initial therapeutic approach that corresponds most closely with the established diagnosis. The workup, observation, or therapies will be the same whether one is treating the confirmed condition or ruling out the condition. If the diagnosis at the time of discharge states probable, suspected, likely, questionable, possible, or rule out, code conditions as if the condition existed until proven otherwise. Inpatient facilities code this. Physicians report a definitive diagnosis or signs and symptoms. So all this is telling us is until we have a definitive diagnosis, we code signs and symptoms. Then once we have a definitive diagnosis, we code the definitive and not the signs and symptoms. Okay, section 2H, cough and fever, probably pneumonia. Inpatient coders can build for probable, possible diagnoses, but outpatient coders can build for confirmed diagnoses only. I'm going to say that again. Inpatient coders can bill for probable or possible diagnoses, but outpatient coders can only bill for confirmed diagnoses. Inpatient code pneumonia, do not code cough and fever because you're inpatient, you can code for the probable pneumonia. Outpatient, you're going to code the cough and fever. Do not code pneumonia. Code symptoms in outpatient setting if a definitive diagnosis is not documented. Okay, this to me is one of the most clear examples that we've had so far because it's giving you an example. Okay, so the rule says inpatient coders can bill for probable or possible diagnosis. So the patient comes in with a cough and fever, and they think probably pneumonia. So that inpatient coder can do the pneumonia. But outpatient coders can only bill for confirmed diagnoses. So because it's not confirmed pneumonia, the outpatient coder has to bill cough and fever and cannot do the probable pneumonia. I hope that makes sense to you guys. I'm going to read an example. A question. If a patient comes into a clinic and has abdominal pain, and the diagnosis given by the physician is rule out appendicitis, could the outpatient coder code the appendicitis? No, because they are only ruling it out. It is not a definitive diagnosis yet. So what would you put as your diagnosis? What would you bill? You would have to bill abdominal pain. So in what setting would the patient have to be in order to code the rule out appendicitis? The patient would have to have been admitted into the hospital. So I hope that this gives you a very clear view. I know we're talking lots of words, lots of reading things, lots of things where you're probably going, okay, what does that mean? Well, I hope this really clears those other slides up and gives you a clear view. Section II.H, uncertain diagnosis. Two exceptions to this rule. AIDS B20 should only be assigned for confirmed cases. Avian influenza J09.X2 should only be assigned for confirmed cases. You cannot do probable. It doesn't matter if you're inpatient. You could only do confirmed cases of these two things. Okay, so admissions from observation care or observation unit. A patient admitted to observation for medical condition which worsens or does not improve. A patient admitted to the same hospital for the same condition, and the principal diagnosis is the medical condition which led to the admission. So you can go from observation to inpatient, because if a condition isn't improved and you've had the same condition and it's worrisome, and if your principal diagnosis is so severe you have to be admitted. You can go from observation to inpatient, but you can't go from inpatient to observation. You would have to be discharged and then turn around and readmitted to observation, but that rarely ever happens. So you can go from observation to inpatient. Okay, admissions from observation unit. Patient is admitted to observation to monitor condition or complication following an outpatient surgery. Is then subsequently admitted as an inpatient to the same facility. The principal diagnosis is that condition established after study to be chiefly responsible for the occasioning the admission of the patient to the hospital for care. It's based on Uniform Hospital Discharge Data Set, definition of principal diagnosis. Patient receives surgery in the outpatient surgery department, is subsequently admitted for continuing inpatient care, and guidelines for assigning principal diagnosis for inpatient admission. So you have to know your guidelines for that. But I'm going to tell you, I know that this sounds foreign as I'm reading it, but as you're doing your examples in your chapter, which I believe you should have done yesterday, also reading your chapter, you're going to be able to say what examples go with which scenario. Okay. Admissions from outpatient to surgery. I'm sorry, admission from outpatient surgery. If admission is due to complication, assign the complication as the principal diagnosis. If no complication or medical condition is documented as a reason for admission, assign the reason for the outpatient surgery as the principal diagnosis. If admission is for another condition unrelated to the surgery, assign code for unrelated condition as principal diagnosis. Now, I don't know what page that is. I don't know what page that's on in your step-by-step manual. If you didn't highlight it, I think you should make these notes because these are important things to know. Or let me see if I can find. If you look on page 44 in 2019, you're going to see admission from observation unit. It is actually under J, admission from outpatient surgery. All of these things, and I'm going to hold this up. I'll hold it up after because I think if I'm doing the share screen, you can't see well. So I'll hold this up after I get finished. Section 3, reporting additional diagnoses. Definition of other diagnoses are additional conditions that affect patient care requiring clinical evaluation or therapeutic treatment or diagnostic procedures or extended length of hospital stay or increased nursing care and other monitoring. Okay, reporting additional diagnoses. Guidelines when neither alphabetic index nor tabular list provide direction. The diagnosis reported in discharge summary should be coded. So let me read that again. The diagnosis reported in the discharge summary should be coded. Resolved conditions or status post procedures from previous admissions that do not have bearing on the current stay should not be coded. You shouldn't pull that out of the history and put it in. History codes if impact on current care or influence treatment. So, for example, if you were admitted into the hospital because you had appendicitis, and 6 months ago you were hospitalized because you had a surgery on your ankle. One doesn't have anything to do with the other. So it's not a reason to pull that diagnosis and put it in from the medical history. But if you have diabetes, that really always needs to be there because that treatment was treated while you were in the hospital and you will have continued care after the hospital for the treatment of diabetes. Abnormal findings. Abnormal findings of laboratory, x-ray, pathologic, and other diagnostic tests, not reported unless provider indicates there's clinical significance. So that's where your medical record is going to tell you. If findings are outside normal range and provider has ordered other tests to evaluate the condition or treatment, ask the provider if abnormal findings should be reported. You can always query the physician or ask the physician. Section 3, uncertain diagnosis continued. If diagnosis documented at the time of discharge is listed as probable, suspected, likely, questionable, possible, still to be ruled out, or similar uncertain wording, code the condition as if it existed. Basis is that diagnostic workup, further workup, and initial therapeutic approach will correspond to the established diagnoses. So even though it's suspected or likely or questionable or possible, they're going to be following up on those treatments. So the diagnoses need to be listed in the discharge summary. ICD-10 PCS, procedures of, replace volume 3, procedures of ICD-9 CM. The 4 objectives guide develop completeness, expandability, multaxial, and standardized terminology. Okay, so I'm going to read my little notes that they have under here, and hopefully that slide will make a little more sense to us. 4 major objectives guided the development of the ICD-10 PCS: completeness, expandability, multi-axial nature, and standardized terminology. The ICD-10 PCS has 7-character alphanumeric code structure. Characters 2 through 7 have a standard meaning within each section, but may have different meanings across the section. If a character is not applicable to a specific procedure, the letter Z is used. The tabular list provides the remaining characters needed to complete the code given in the index. So that's the conclusion, and I'm going to stop our share so that I can point out to you guys. Hi, I know this is not my favorite section. I really think that should be before we get into CPT coding, but that's the way the book is laid out and nobody asked me. So I'm kind of just going to start, because this way, Rachel, you can kind of see where I'm looking here. I'm going to, let me see if I can push it down. Okay, so I'm opening my ICD-10. Let's see if I turn this light off. There we go, that's not quite so shiny. And so this is what I'm looking at. We're looking at our dedication, our contents, and then this is our symbols and conventions, and I'm going to continue on. I want to show you where I'm finding these guidelines so that you can actually look in your ICD-10 without having the page number. It says part 1, and then it's the introduction. And then you just go along, and you're going to see at the top where the correlation, like this is selection I, but we went a little bit further. So if you kind of get in and explore, if you see, like here it says section 2, where I was saying section 2H, section 2I, when you get in, you can kind of see as you go on. Let me get there. I'm sorry. I'm going upside down. Here, I'm still going. I'm sorry. There's lots of guidelines. Okay. Here you see it's A, B, C, D, E, F, G, H. You're going to be able to correlate the numbers with the letters as you get into that and look. I'm actually going to be uploading a little video, and I'm going to do that on like the little poll, or the it's kind of the same place that I put our week at a glance. I'm going to put one on from YouTube, a little video that just gives you an overview of what the ICD-10 is, just so maybe that can give you some extra information. I don't want anybody to be, if you haven't been through the ICD-10, I don't want you to feel nervous, because you're going to get into the ICD-10. Just kind of dipping a toe in, but we're going to get very in depth with it. So I'm sorry this was not the most exciting lecture, but if you have any questions, if you need me, please let me know. I hope you guys have a wonderful evening. Bye-bye.